You walk onto shift and a handful of nurses are rushing back to the OR. In report, you get that a very sick patient is coming in for an expected preterm delivery. The plan will be to go under general anesthesia for the C-section. As you get back there, the baby is preterm and is taken to the NICU, and shortly after, the mother starts to code. Your patient is being worked on for an extensive amount of time. She's unstable and needs to be placed on ECMO. Later results reveal an ejection fraction less than 30. This situation was what spiked my interest in a condition called peripartum cardiomyopathy. PPCM is a severe cardiovascular complication in relatively healthy women during pregnancy, and 80 to 90% of PPCM cases show up within the first month postpartum. Developing PPCM causes significant left ventricular dysfunction and heart failure, which can be fatal. It will be important for us as midwives to recognize actual or impending heart failure and have access to diagnostic testing and treatment options. Prompt recognition and referral to a cardiologist are essential for the survival of these women, their recovery, and the possibility of PPCM affecting future pregnancies. So the etiology for PPCM is unknown. However, there are risk factors: African descent, age, which 50% of cases are women in their 30s, pregnancy-related hypertension, multiparity, multiple gestations, obesity, and anemia have all been seen. The prevalence of PPCM in the U.S. is about 1,000 to 1,300 women each year. Based on some studies, it's been suggested that hypertension and preeclampsia correlate with the predisposition. And then looking at the incidences, it varies depending on geography and socioeconomic status. Overall, occurring 1 in every 3,000 pregnancies. The rates are lowest in Japan, and it's about every 1 in 20,000 births. Rates are highest in Nigeria and Haiti, and that's 1 in every 100 births. And then overall, it disproportionately affects Black women, accounting for half of all of the cases, which is really significant considering less than 15% of the U.S. population is Black. And then when looking at the mortality, an enlarged heart after 6 months postpartum leads to significant lifelong effects like chronic heart failure, arrhythmias, aggressive therapy, mechanical devices. And then mortality differs from racial groups and geography locations, but it ranges from 3 to 28% in the U.S. The pathogenesis of peripartum cardiomyopathy is multifactorial. The hormonal vascular theory suggests that maternal hormones from the pituitary gland and the placenta play a role in the development of PPCM. So after delivery, angiogenic balance is essential in allowing that safe separation of the placenta off that uterine wall. And researchers show that there's 2 dangerous angiogenic hormones present in maternal circulation. That's prolactin, and then the VEGF, which is the vascular endothelial growth factor receptor, SFIT1, and that's from the placenta. And this SFIT1 levels are increased in PPCM, preeclampsia, and multiple gestations. And that's due to that larger placenta releasing more angiogenic hormones. There's also a genetic predisposition, so like hypertension disorders and certain genetic susceptibility may both cause PPCM through different mechanisms. As a midwife, it'll be essential to differentiate normal cardiac-related changes from symptoms that require further evaluation. It's important to know that half of all women in the second trimester experience shortness of breath, palpitations, and hypoxia. And we know this just due to the normal changes that take place in pregnancy. Noting the onset of the symptoms is critical when considering PPCM, especially if it's within the last months of pregnancy and up to 6 months postpartum. The onset and the severity of the symptoms are directly related to the declining ejection fraction. PPCM symptoms include fatigue, edema, fluid in the lung, shortness of breath with activity and lying flat, feeling your heart racing or like it's skipping a beat, orthostatic hypotension, an increase in nighttime urination, and then swollen neck veins. Signs to watch for in the postpartum period include prolonged swelling in the lower extremities, shortness of breath, the mother's inability to breastfeed, and this is just because they're so sick and exhausted and they don't have the energy to breastfeed. So this is a diagnosis of exclusion. The new onset of symptoms of heart failure would happen in the last couple months of pregnancy or within the first 6 months postpartum. They'll have left ventricular systolic function less than 45%, and then they'll have no other cause of heart failure. So there cannot be an underlying cause, whether it's a valve dysfunction or heart failure of any sort. Like, it has to be a new onset or a new diagnosis. The exam, you'll see a left-sided congestion, like pulmonary rales. You'll see right-sided congestion, like that jugular vein distension and edema. You'll hear an audible S3 gallop, which can also be normal in pregnancy. Tests. The echocardiogram is the most useful in showing that left ventricular ejection fraction that's less than 45%. It also will show left ventricular dilation, pulmonary hypertension, mitral and tricuspid regurgitation, and intracardial thrombi, because it's not being able to pump it, so you can get little blood clots in there. The electrocardiogram can show a normal rhythm and then non-specific ST segment and T-wave abnormalities. A chest x-ray, you could maybe see some pulmonary edema, enlarged cardiac silhouettes or pleural effusions. And then the labs, you'll see an increased B-type peptide, or that BNP, and then the N-terminal pro-BNP, and then your troponin will all be elevated. The diagnosis of peripartum cardiomyopathy would be given in pregnancy or in the early postpartum periods up to that 6 months. Differentials could include myocardial infarction, severe preeclampsia, myocarditis, pericarditis, amniotic fluid embolism, sepsis, and drug toxicities. Therapy is huge. Therapy in that first year postpartum is going to be really essential in the recovery of PPCM. There have been higher recovery rates seen in PPCM survivors compared to heart failure with the decreased left ventricular ejection fraction. And then wearing that cardio defibrillator or cardioverter in recovery is going to be really important for the severe left ventricular dysfunction for those cases. Medications. The medications are used to reduce the preload, improve stroke volume and cardiac output, and optimize cardiac contractility. Inotropic drugs, vasopressors, antithrombotic medications, and mechanical circulatory support are also used. Beta blockers, ACE inhibitors, mineralocorticoid agonists are used in the first year to 6 months postpartum. The exact duration of that treatment is unknown. However, gradual tapering of the medication is suggested while observing the patient's signs and symptoms closely. So that could be an area of further education and further research as well. Breastfeeding, there's no significant evidence. According to the American Academy of Pediatrics, the PPCM is not a contraindication for breastfeeding. Therefore, stable women should not be discouraged from breastfeeding. Drug use to manage heart failure are safe and only show up in small amounts of concentration in the breast milk. ARBs should be avoided as they are secreted in the breast milk. And then thinking back to that normal hormonal vascular theory, stopping breastfeeding would reduce the hormone prolactin, and that could also be helpful in severe cases. Having a familiarity with PPCM is going to be really important. This mimics normal pregnancy-related changes, and I think looking back to my story of my patient who came in and had this emergency C-section and was coded and had to be put on ECMO, and looking back at her story and her shortness of breath earlier in pregnancy, and it just kind of if we could just listen, right? If we could listen to our patients, and more research needs to be done so we have screenings available. So if people are having these signs and symptoms of normal changes, or they seem more like cardiac changes, that we can be screening these women for the potential to have peripartum cardiomyopathy. Also, that prompt recognition and referral to a cardiologist is going to be essential in their survival. We also cannot forget that Black women are disproportionately affected by PPCM. And then also, future pregnancies can be dangerous. Women or their partners may need to have sterilization done. They may need to terminate a pregnancy. There's lots of maternal complications that come with this, and there's lots of complications that can come with a preterm delivery as well. So we need to be giving all of these families the grace and compassion and the resources and support as they go through this really rare occurrence.